Yeah, okay. Can you see that clearly?
That's perfect. Thank you.
Okay, good afternoon, everyone. Greetings from a very cold and wet and miserable UK today, although I suspect it's a little warmer than where Rita was speaking to you from. I'm actually at home in Hull in the United Kingdom, and I'll show you roughly on a map where that is in the moment, just to give you a bit of context. And I'm going to talk to you today about translational research in nursing, and I'd like to thank the faculty and Professor Murdy in particular for inviting me to participate with you today. So this is where I am on the far left-hand side up there in the UK, and I'm in Hull, which is the opposite side of the country from Manchester, which is about 300 kilometres to due north of London. So quick disclosure slide. So just to give you a bit of an overview then of what I'm going to talk to you about today, I want to offer you an overview of the relevance of translational research for nursing research, practice and education. This is quite a large topic, so what I think I'm going to do that will make it come alive for people is to talk about some examples of research topics and methods that go with them that illustrate the future of translational research for nursing. And in doing that, I'm going to talk a little bit about the way things have developed in the past as well. So I hope that's going to be okay for everyone. So first of all, I just wanted to have a quick look at the term translation. It means quite a lot of things, and we think about it automatically in reference to language. But the dictionaries also talk about the process of moving something from one place to another. So similar terms being things like relocation, transfer, moving things, movement generally. So when you look at the definitions of translational research and you bear that in mind, what the literature tells us is that translational research is about knowledge or research translation, the process through which research knowledge is not only created, but circulated and adopted into clinical practice. And I've highlighted the adopted into clinical practice because that's the part of that process with which we have the most problems. And I'm going to explore that as an issue shortly. So knowledge or research translation is very much not simply a linear procedure, but it involves a lot of quite complex processes and symptoms and interactions between the researcher and the knowledge users. And again, that's something that we have had some difficulty with in nursing and still do. So in terms of other terms that also you'll see in the literature relating to translational research, in the UK and Europe generally, we tend to talk about research utilisation. In the US, terms like research dissemination, research diffusion or knowledge uptake are used quite regularly. Australia and Canada talk about knowledge translation or knowledge to action. And of course, the whole world talks about evidence-based practice. And this whole idea of translational research is about making sure that the evidence gets into practice. And that makes it sound very simple. But in fact, as we'll discuss shortly, you'll see that it's not really a very simple process at all. So if you look at the literature, let's just do a little bit of theory about modes of translation of research into practice. And we think about referring back, let's refer back to the things that Rita was talking about in terms of COVID-19 and the research that's going on there at the moment, particularly into vaccines. This lends itself very well to a discussion about how research is translated into practice. And what I should say, of course, is that research that's going on into COVID-19 vaccines at the moment is actually going to be very easy to transfer to practice. The doing of the research is actually incredibly difficult because vaccinating people who are then exposed to the virus is extremely problematic. But it's once the research is complete, actually transferring that into practice is going to be very easy because the whole world wants this vaccine right now. It doesn't always work like that with nursing research topics, and we'll explore that in a few minutes. So often the first process, particularly in research that's developing new treatments and interventions, is to translate research from a treatment development, often in animals, to human beings. So in the early days of the development of vaccines, what will have happened is that researchers will have developed a vaccine and tested it on animals, and it hasn't been at that point anywhere near a human population. And this is this will be often basic research in with laboratory research, epidemiology, for example. And this is how new knowledge of diseases and mechanisms are developed into clinically relevant regimes. So the first stage in translating a piece of research is to move it from perhaps an animal or laboratory model into human beings. Once that's been taken place, then we move on to the next mode of translation, which is translation to patients. So there's been probably been some testing in healthy humans, for example, and then we have to start thinking about testing drugs and interventions, and in this case vaccines, on people who are not healthy human beings, but people who are already receiving healthcare. So, and the idea of that phase will be to test the efficacy and the effectiveness of interventions in that population. Now, the bit that we're going to focus on today then is the third phase of translation, which is translation into practice. And this is the very important phase of research. It's what research aims to do, is to disseminate the research for system-wide change, moving, for example, evidence-based guidelines into health practice. The phase also focuses on the idea of practice-based research. So the idea being that the research is based on practice in the first place to make it possible. And this is often what we call the dissemination phase of research, the implementation of the research, diffusion research. And like I've just said, probably in the case of the COVID-19 vaccines that are being developed across the world, this is the bit that's actually going to be relatively easy, because the research itself has been very difficult. And what I should say to you is that normally it's actually the other way around. So just a little bit of background theory to that. So what I want to do is I want to provide you with some examples of past research and some of the difficulties that we've had in implementing research in practice in the past, and why we need to focus on this idea of translational research and that last phase of the research process where we're actually making the research findings work and become embedded in practice. So here's a really good example from the wound care literature. It's a topic of mine that I'm particularly interested in, and I've taught a great deal over my academic career. So back in 1962, so that's the year, was it 62? Yeah, 1962. So the year after I was born, so that must be nearly 60 years ago now, there was a publication in Nature Journal, which is the journal that's at the top of the tree as far as impact factors are concerned. And as nurses, the likelihood of us ever getting anything published in such a journal is going to be quite limited, but you never know. So Winter did some laboratory research. So there in the early phases, some basic research looking at the formation of scabs and the rate of epithelialization in superficial wounds. And what he did was he created superficial wounds in the skin of young pigs. I think there were 36 of them, if I remember rightfully from the research. And then he randomized the wounds into 2 different treatments. And he looked at what happened if the wound was left exposed and dry, which would have been very much normal practice in those days, and probably is still normal practice in some clinical settings across the world. And what he found was that where there was a superficial wound in the skin, if you actually covered the injured area with a plastic film, what actually happened was that the wound healed much more quickly. It didn't have a scar, and it was very clearly demonstrated, because pig skin is very similar to human skin, that actually not having a dry scab and having a wound that was slightly moist underneath was actually going to heal much more quickly. And the other thing that he also noticed was that the wound was the lack of formation of a scab meant that there was less scarring from the wound. So that was a pretty important piece of research, which was the very beginning of the work today. So you could argue that in terms of our phases of research utilization and transmission to practice, that was the bit before the phase 1 that I was just talking about now. So then things moved on, and we moved into phase 1, where only a year later, some researchers called Hinman and Maybach looked at this from a slightly different angle in 1963. So they moved into the translation to humans phase. And what they did was they looked at the effect of air exposure and occlusion using a plastic film on experimental human skin wounds. So we moved from the animal to the human. They used healthy human volunteers. They created skin wounds on the inner forearm of the volunteers, and they also used a neomycin preparation on the skin for ethical reasons, to make absolutely certain that the individual wasn't going to get an infection. And remember that the ethics of research and the things that Rita's been talking about were really not considered in anywhere near as much detail in those days as they would have been today. And they had 2 groups where they left one group's wounds exposed, and the others that they covered with a polythene film. And they found, of course, like Winter did with the animal experiment, that more epithelialization of the wound and better healing was apparent in group 2. So already we're now in a position where we can see that in healthy human beings, this new research was making very significant progress by 1963, because we knew that it was going to work in a human model as well. So over the coming up for 60 years since then, there's been a whole raft of innovations, products developed. So all of those film dressings that nurses work with today in various settings, from chronic wounds through acute wounds to protection of intravascular sites and that kind of thing, have been well embedded in practice. But what's really interesting about this, from my own perspective of having been a nurse working in an orthopedic unit in a hospital in the 1980s, is that actually it took from 1963 to the 1980s for this kind of wound care to even start to be embedded in practice. So I think what that does is gives us an example of, I feel, some research that's now been translated very clearly into nursing practice. I'm not completely convinced that all nurses understand the origins of that research, but it's become very common practice. But it has taken about 55 years to get to the stage where we are now. So this process of translating what seems to be very simple ideas from new knowledge is actually very time consuming, and it takes quite a lot of effort to get things to happen. So I think moist wound healing provides quite a good example of if you like, a successful but long-standing development of translation into practice. And it's continuing to develop today. So, for example, I don't know about in Turkey, but in the UK now, the recommendation for first aid for the use of burns is to use kitchen cling film to hold the moisture of the skin in the first aid situation. And that's actually taken a little while to develop, because that's come from some processes that were used on board ships that were bombed and were on fire in the Falklands War in the 1980s. So it's taken a little while for that to continue to develop. These things take quite a bit of time. So just to move back then, before we look at some more problematic areas from this point of view, what we're thinking about here is, oh, sorry, just go back one, is nursing knowledge and science, and the what we call the gap. So there's been, probably since the 1980s in particular, there's been a very long discussion that's taken place in the nursing literature, and in fact to some degree in the medical literature, about the notion that there's a gap between the research that we have available to us and what actually happens in practice. So in terms of evidence-based practice, you know, we all know that definition: integration of available evidence with clinician experience and patient preference and values in mind. But the problem with that definition of evidence-based practice is, again, this is something that the transference of what we know to be the evidence to have it happening in practice is problematic. And I'm going to give you an example of that in a minute. So when we talk about the theory, research, evidence, practice gap, we're talking about the gap between what we think and we know is best nursing practice, research and education, and actually what nurses really do in routine care. And there are lots and lots of examples of really good bodies of research that just haven't yet managed to make it to embed themselves in everyday nursing practice. And there's a whole body of literature around the theory practice gap if anyone wants to take a look for that. So I just wanted to mention a little bit about, go back to wound care for a few moments and talk about some of the things that can make a real difference to having research embedded into practice. So back in 1989, when this book was published, I was still a ward sister working in an orthopaedic unit. And this was the point at which the whole notion of moist wound healing, and we changed our practice in terms of wound care, actually happened. And in the UK in particular, there was a really what was a groundbreaking book by Walsh and Ford that looked at nursing rituals. And in the UK at that time, we'd previously had all sorts of unevidence-based practices, like drying wounds out with the end of an oxygen tube, painting egg whites onto patients' pressure sores, giving the idea that they would help it to heal because it contained protein. And this book really started the revolution in making nurses really think about whether what they was doing was either evidence-based or logical. And this just gives you an example from that book that talks about, you know, how we used to just put a dry dressing on a wound, and still in 1989, despite Winter's research being from 1962, we were doing that until practice changed quite dramatically in the 1990s. So if you look at the research about the gap between research evidence and nursing practice, there's again a whole body of literature that talks about what is the reason why, because we know this to be the case. What's the reason why nurses don't use evidence in practice? And there's a body of literature that goes back again to the 1980s that talks about this. And so I've just collected some of the explanations for this gap. The first one is that it's perceived that nurses don't do research. Proper clinical nurses who are working at the bedside aren't the people who do the research, someone else does it. So as a consequence, nurses don't believe that that research has any real relevance to them and their practice. And not only that, they perceive research in nursing to have come from maybe some people who are nurses who work in the ivory tower of research departments and universities and that kind of thing, and therefore they perceive again the relevance of research to their practice to be not really an issue. And one of the problems with that, of course, is that they in a way are kind of right, because there is this difference, if you like, between the way that they think and the way that the people who create research think. And they additionally think that not only is research not relevant to me, but actually they don't understand it as a result of it, because the terminology that those of us that work in research areas use and the language in which research papers are written is quite difficult for practicing nurses to get their heads around. So as a consequence, nurses don't read the evidence, and they don't really understand the evidence. So their ability as individuals and teams at a clinical level to be able to implement a piece of research is quite problematic. The additional problem goes back to the researchers, in that the way that researchers use research methods, and this is particularly problematic for medical evidence that's created in pieces of research like randomized controlled trials. Nurses, when they look at that evidence, have difficulty in finding ways to translate that into practice. So that causes quite a lot of problems for them. A really important side of this is about the way that the evidence, the research, is actually created. And I suppose that's the most important thing about what I want to say today, is that if you're going to be a researcher, I'm thinking about all of the doctoral and PhD students that have joined this wonderful event today, that you really must think about the fact that evidence is not always created with implementation and translation in mind. So if we create evidence without thinking about how it's going to be implemented at the end of the research cycle, then we're going to have difficulties with it. On top of that, it's actually very difficult to translate research to practice. Newly educated nurses who have been taught in universities about evidence-based practice, they've been encouraged to learn how to read research, they've been encouraged to distrust research findings that are published in journals. When they get out in practice, when they qualify, and even before, they're often met with a culture that distrusts the evidence and wants to maintain the status quo. So very quickly, student nurses who become qualified nurses are socialized into doing things the same way that they've always been done, because their more experienced colleagues want to keep things that way. And there's a really good reason for that. Changing practice in nursing is very difficult, time-consuming and hard work. And one of the issues we have increasingly now is that nurses feel they're much too busy to make the effort to go through that change process in order to translate evidence into practice. And, you know, at the moment, we already had a global shortage of nurses, and that's been made increasingly difficult by the pandemic situation we're in at the moment. And I certainly get the impression from conversations I've had with nursing research colleagues is that nursing research has currently virtually stopped, partly because of the issues that Asi was talking about earlier on, where, you know, it's very difficult to socially distance when you're doing nursing research. But secondly, all of the money is currently focused on trying to resolve this big pandemic problem that we've got. So, you know, when we get going again, it's going to be incredibly difficult. But we still have this raft of evidence from the last 30 or 40 years that we know has been problematic to put into practice. So what I want to use as an example of that is hand washing, because it's something that all nurses do, no matter what setting they work in, what kind of patients they work with. And I think it's very relevant at the moment. So let's just have a little look at the history of hand washing. So it goes back to 1850. Hard to believe, but before 1850, no one had actually realised that hand washing was so important to preventing people from dying from infections. So an Austrian doctor called Ignaz Semmelweis noticed that hospital-acquired diseases were transmitted by the hands of healthcare workers. And he noticed that because he saw that doctors went to the delivery suite to deliver babies after performing autopsies with a disagreeable odour on their hands that seemed linked to the incidence of puerperal fever and death in mothers and babies. So from that observation, he recommended that the hands of doctors who were going to the delivery suite were scrubbed in a chlorinated lime solution before they contacted every patient. I hate to think what that solution did to their hands, but it was the 1850s and things have moved on a little since then. And the mortality rate in the delivery suite fell dramatically to 3% and remained low. So astoundingly good news from the point of view of infection prevention back in 1850. But would you believe that the first national guidelines for hand hygiene were not actually published until the 1980s? So it took 130 years for that piece of observational research to end up even being written down as a guideline for practice. And we all know today that we have most people across the world now use the World Health Organization's guidance that centers around the 5 moments of hand hygiene, that we should all cleanse our hands in whatever way is recommended in that situation, before touching a patient, before a clean aseptic procedure, after body fluid exposure, after touching a patient, and after touching patient surroundings. And that, of course, is particularly important at the moment because we're trying to protect everyone from the transmission of COVID-19. But is that reality? So we know from research, copious research, over 100 years worth of it, that the hands of care workers are the most common source of infection transmission during healthcare. The practice of decontaminating the hands is the absolute and most important method of breaking the chain of infection. It's a universally acknowledged fact based on 1.5 centuries of evidence, and performing hand hygiene every time should be a fundamental activity carried out by every healthcare practitioner. Now, I can't see everybody at the moment, but if I ask you the question, if you ask anyone working in a care setting if they always carry out hand hygiene every time, what would they say? And what would you say? When you're working in a healthcare setting, would you carry out hand hygiene every time? Well, given the evidence, we'd like to think that we do. So here's a piece of research from this year. In fact, it's so recent it hasn't got a volume number for the American Journal of Infection Control at the moment. These researchers in America have published this major article about the impact of COVID-19 pandemic on hand hygiene performance. And what they did was they estimated hand hygiene performance rates using an automated hand hygiene monitoring system installed in 74 adult inpatients units. So a big study in 7 hospitals, 10 paediatric units and 2 children's hospitals. And they used a segmented regression model to estimate the change and movement in hand hygiene practice rates, importantly, in the 10 weeks leading up to the COVID-19 related milestone event, i.e. school closures. That for us in the UK happened on the 23rd of March, and for 10 weeks after that happened. And what they found was that there were 3 effects that emerged, all of which were statistically significant. So first of all, average hand hygiene performance rate increased from 46% to 56% in the months preceding pandemic-related school closures. Okay, so the original performance rate of hand hygiene was less than 50%. So less than 50% of the time were the healthcare workers undertaking hand hygiene when they should. And that reflects the figures across all of the research that tells us about hand hygiene compliance. And those are the figures that are telling us that the research that started in 1850 is still not embedded in healthcare practice, despite what we know about this. It improved a little in the months preceding the pandemic, and then that was followed by a further upward trend to 62% at the time that school closures occurred. After that, the rates remained at 60% for 4 weeks before declining back to 54%. So, really big evidence that a really fundamental research process has still failed 150 or more years down the line to embed itself in practice, even in the middle of a very serious global viral pandemic. So, a little bit, what's going on here? What's happening here? So, in terms of thinking about the research process, we have to think about where we are in this. So what's the problem here? What's going on? What's this theory, evidence, practice gap about? It's about a lack of attention to the later stages of research. It's about two main things. It's about the way that we disseminate research in a way that it can be used in practice. And it's also, and probably more problematically, about the implementation of local, regional, and global research. And what we have to remember is that, we think that hand hygiene, for example, is a relatively simple process, but all processes of embedding of research in practice take place within very complex healthcare systems. There's a complex system of interactions between the researchers who created the research and the knowledge users. And that interaction very much varies in terms of its intensity, its complexity, and the level of engagement depending on the nature of the research and the findings, as well as the particular needs of knowledge users, the nurses who are actually going to use this evidence. So thinking about hand hygiene then, this is from a fairly recent study, again from the US, where this research has looked at it's a review that's looked at what the determinants are of whether nurses actually undertake hand hygiene according to the World Health Organization or not. And what they found from their very in-depth review of the literature is that there are really 4 areas in which there are factors that affect hand hygiene compliance. So in terms of institutional factors, things like the type of unit, whether it's an infection control unit, whether it's an intensive care unit, whether it's a special care baby unit, what type of job the nurse has, even things like shift length, how many shifts they do per week and how long they are, understaffing and overcrowding of units. So one of the reasons why things seem to be particularly much worse at the moment, and a lack of commitment to the idea of a safety culture in some areas. I think one of the interesting ones is if you ask nurses about, if you have the conversation with them, which is unusual, we don't talk about this problem because nobody likes to admit that they only wash their hands 50% of the time that they should. Research tells us that nurses change their behaviour or don't according to the situation. So if they're wearing gloves or protective gear, they're less likely to wash their hands. They talk about the access to resources such as dispensers and sinks. They talk about that patient not needing for me to wash their hands They say they forget. They say they have a high workload and too much to do. And it also varies according to the time of day. Night time, the hand hygiene compliance actually goes down. Apparently, there's even a difference between gender in that female nurses and medics are more likely to wash their hands than male nurses and medics, and that's a very interesting area of research to look in. And also we know that hand hygiene products cause lots of problems for staff in terms of their skin on their hands and stuff like that. It's the psychological issues that are really important, and this is the area where we need to think about how we can work on this in terms of translation of research. So what they found here was that research tells us that it will make a difference if the nurse perceives themselves as a role model. It makes a difference if they are subjected to peer pressure. And if you don't talk about it, you can't have peer pressure. So there you go. It's also about things like perceived ease of performance. And it's also about how much the nurse perceives that they are at risk of infection. So it doesn't really relate to their perception of giving the patient something that they've got. They are more concerned about their risk. So if they know a patient has an infection, they will more likely wash their hands up to about 70% of the hand hygiene moments because they perceive that as being a risk to them. So all really interesting stuff that's starting to give us some pointers about why just telling nurses, putting a sign up that says, please wash your hands, is not actually going to help the evidence to get into practice. So one of the issues in research translation or translational research is about the idea of knowledge distillation. So we've just talked about the fact that nurses don't always find research very easy to use, certainly not very easy to read, and they don't always understand its relevance to practice. So when we talk about knowledge of distillation, we're talking about the synthesis of findings, bringing together the most rigorous research available on a specific topic and into systematic reviews and guidelines. So, for example, the Joanna Briggs Institute in Australia is a very well-known global organisation. There are several around the world who do just that they bring research findings together and they synthesize them in a way that they can be presented to clinicians as practice guidelines or fact sheets and through education. But of course, that's all very well. You can produce those guidelines and fact sheets, but whether people then actually read them and use them is, the World Health Organization hand hygiene guidelines are a very simple model for what you should do and what you shouldn't do, and we still don't do it. So it's very much more complex than that, but actually it's important to have the knowledge distilled for nurses to be, or certainly nurses who are driving change in practice, to be able to use it. So one of the things that we have to think about when we're thinking about the research process and being researchers, and I'm assuming everybody's joined the session today because they either are or are planning to be someone who undertakes research, is that we have to start building knowledge into knowledge transfer, knowledge translation into research design. And in terms of what the literature tells us and what research tells us is that there are really 5 principles to that. When you begin a research study and during its progress, you should plan with the end in mind, and not the end of the research as in the dissemination, what paper shall I write, but what's going to happen to my research when I've written the paper and it needs to be translated into practice. We need to produce evidence that's useful, and we need to begin that by identifying research problems to drive our research questions that are totally relevant to nursing practice. So, for example, Rita was talking earlier on about the processes of missed care in older people, the care processes that older people are missing out on, the things that aren't happening for people in terms of their health and social care that they should. That's a global and growing and really big problem in terms of the ethics of healthcare, for example, but doing things that are actually going to be relevant, that are going to be able to be translated into practice, are really important. So at the beginning of the design, we have to think about how we're going to design the research so that we can then translate and exchange it into practice, and by seeking outcomes that last. And what all of the literature tells us, and I'll just focus on this for a few minutes before I finish, is that we need to involve end users throughout. If you create research studies that involve the people who are ultimately going to implement the research, then the rewards will be that they've been involved in that research, it's meaningful for them, and then they are more likely to take that research forward into practice. So I just want to leave you with some examples, again, from the hand hygiene literature, of the kind of studies that are quite meaningful. And what you'll see is that there's a theme here of user participation. And that's why participatory methods of research, so there are methods such as action research, participatory design research, that lend themselves really, really well to nursing studies that want to engage with the people who need to implement the findings in the first place. So this study is from Vietnam, and it's actually not about nurses, it's about school teachers. So if you look at the design part of this study, which was about teaching hand washing with soap for school children in a multi-ethnic population in northern rural Vietnam, what they did was implemented a study in 2 phases. They undertook a formative research project over 5 months and an action research project with a school-based hand washing intervention study in 2 rural communities. And what's important about this is that the next part says that based upon knowledge from the formative research in 2008, the school teachers from 4 selected schools in the study communes actively participated in designing and implementing the intervention. So already they were starting from a point where the people who were going to make the real difference, or potentially make a real difference, were involved in the study from the beginning, and they were also people who understood the participants. But one of the issues that was created by that was, of course, that when we get to the results and we look at whether this intervention was actually embedded in everyday life, they found that there was a lack of reminding the children to undertake hand washing on a regular basis at home. So if you go back to the design of the study, actually what might have been more effective, but of course much more complicated, would have been to involve the children's families in undertaking the research and had them do the teaching of the children, and that might have embedded it in practice a little bit more. So a more recent study uses a participatory design research, and I just wanted to highlight the principles, if you like, of participatory research design. So what this does is it emphasizes collaborative participation of trained researchers as well as local communities, in our case nurses and patients, in producing knowledge that's directly relevant to the stakeholder community. So what these kind of research methods do is look at participatory collaboration, and they empower the participants to be deeply involved in and understand the research. The research then generates new knowledge, and action takes place through change, because the research is about real life experience and it's evidence in terms of the outcomes of real life experience. So I want to leave you with a final example of how this might work, and I'm going to refer to hand hygiene again. We might as well stick with the same thing. So this is a study in 2017 that was conducted in Italy, and what these researchers wanted to do was to explore the perceptions and unconscious psychological processes underlying hand hygiene behaviour in intensive care nurses. And that goes back to the things that I was saying, is they clearly looked at what the literature says about why is it difficult that we have trouble implementing hand hygiene practice in practice. So they undertook an action research intervention, and what they did was they undertook development and validation of a questionnaire and things like structured interviews, team discussion, and designing the project with the people who they were looking at. So they, for example, had general workers, staff nurses, student nurses participating in various stages of the research. And the results are quite interesting from that point of view. And it goes back to what I was just saying about what is the reason that nurses don't undertake hand washing. And they said that social hand washing was a structured and efficient habit, or lack of it, which follows a pattern of there's a cue. So there's a reason to wash your hands. Then the behavior is undertaken, and then there is some gratification for the behavior. So if we don't have the cue and we don't have the gratification for the behavior isn't going to happen. And what this study clearly showed, as has happened in other studies in the past, that it's the perception of something that's dirty that starts unconsciously the process of social washing. So what they're suggesting here is that hand washing is a ritualistic behaviour. It's driven by very deep and unconscious patterns and social habits that affect professional practice, and that it's creating those professional habits that's going to be important in the future of translational research in this area. So I hope I've managed to give you a bit of an overview of some of the issues around translational research and nursing, and that's giving you a little bit of food for thought, and I'd like to thank you very much for listening.